All right, today we are diving into osteoporosis. My goal here is to give you a really practical, high yield framework that you can take with you and use like tomorrow on your clinical rotations.
Okay, let's kick things off with a case that is an absolute classic. You are going to see this, I guarantee it. A 68-year-old woman, a simple fall from just standing, and boom, a broken wrist. This exact story should have one diagnosis just screaming at the top of your mind. So, to answer that, we first need to get super clear on how we actually define osteoporosis. Because, it's not just one thing. It really has two very different but equally important definitions.
So, first up, you've got the official by the numbers definition from the World Health Organization. This is all about bone mineral density, or BMD, which we get from a DEXA scan. If that T-score, which compares your patient's bone density to a healthy young adult, is minus 2.5 or lower, that's osteoporosis. Simple as that.
And this is probably the single most important clinical pearl to take away from this, a fragility fracture is osteoporosis. That's it, period. The patient from our case, she has osteoporosis. It doesn't matter what her DEXA scan shows. Her bone has already failed the stress test of just living. That's the clinical diagnosis right there.
And check out this image. This shows another really common and often super sneaky sign of the disease, vertebral compression fractures. A lot of times, patients have no idea they even have them. They might just feel like they're getting shorter or a bit more stooped over. So if you're looking at a chest x-ray for something else and you spot this, that patient has clinical osteoporosis.
So what is physically happening inside the bone that makes it so weak it can break from a simple fall? Well, it all comes down to a fundamental imbalance in how bone normally maintains itself.
Think of it like a never-ending roadwork project. You have one crew, the osteoclasts, that are constantly digging up and removing old, worn-out bone. Then you have another crew, the osteoblasts, that come in right behind them to lay down fresh, new bone. In healthy bone, they work in perfect harmony. But in osteoporosis, the demolition crew, the osteoclasts, are just going wild, and the construction crew just can't keep up. The result? A net loss of bone.
So we know what it is, we know why it happens. The next big question is, how do we find these patients before they break a bone? Let's talk about screening. This is a question you're going to face all the time in primary care clinic. Obviously, we can't screen everyone, so who are the high-risk people that the guidelines tell us to focus on? Well, the guidelines give us a really clear starting point. For women, we screen everybody at age 65. For men, a little later, at age 70. And of course, you're going to screen people earlier if they have other risk factors, if they've already had a fragility fracture, or, and this is a big one, if they're on long-term steroids like prednisone. Okay, so you order the DEXA, you get the report back, and you've got to know which number to look at. For postmenopausal women and men over 50, it's all about the T-score. That's your diagnostic number. But for younger folks, you want to look at the Z-score. The Z-score compares them to people their own age. So if that's really low, that's a huge red flag that something else is going on, a secondary cause of bone loss. And that leads us perfectly into our next job. See, getting a diagnosis of osteoporosis, especially if the patient is young or it's really severe, that's not the end of your thinking. Nope, that's the beginning of your investigation. You have to put on your detective hat and ask, why? Is this just standard age-related osteoporosis, or is there some other medical condition that's actually causing the bone to thin out? A low BMD is a sign, and it is your job to figure out the root cause. So where do you start? Well, with a basic lab workup. This panel here hits all the big stuff. You want to get a CBC, a comprehensive metabolic panel, to check out their calcium, kidney function, liver function, and you absolutely have to check a vitamin D level. And if that calcium comes back abnormal, your next reflex should be to check a PTH level to look for a parathyroid problem. And here is a really important differential diagnosis to keep in your back pocket. Osteomalacia. They sound kind of similar, but they're completely different problems. Osteoporosis is a problem of not enough bone. Osteomalacia, on the other hand, is a problem of soft bone because it's not mineralizing properly. This is usually from a really severe vitamin D deficiency, and the treatment is totally different. Okay, you've made the diagnosis. You've ruled out secondary causes. Now it is time to build a treatment plan. Treatment is really a stepwise process. You always start with the foundation. That's lifestyle stuff. Weight-bearing exercise and, critically, fall prevention. Then you make sure they have the basic building blocks, enough calcium and vitamin D, before you even think about moving on to prescription drugs.
Now, for most of your patients, the first prescription you're going to write is for a bisphosphonate. These are what we call anti-resorptive drugs. That's just a fancy way of saying they put the brakes on those overactive osteoclasts we talked about, which finally gives the bone-building cells a chance to catch up.
But listen, not all bisphosphonates are created equal. This is really important. If you look at the table, you'll see that alendronate, risodronate, and the IV drug zoledronic acid, they have the best data. They're proven to prevent fractures everywhere: hip, spine, other sites. Notice that ibandronate is only proven for spine fractures, which is why we don't usually pick it first.
Okay, this is a massive safety pearl. Huge. These drugs work by stopping bone breakdown, right? Well, that also cuts off a little internal supply of calcium to the bloodstream. So if your patient is already vitamin D deficient and can't absorb calcium from their food, starting one of these drugs can cause their blood calcium to plummet. So the rule is simple. Check and fix vitamin D and calcium levels before you give that first dose. Always.
Now, these drugs stick around in the bone for a long, long time. So after a patient has been on one for about 3 to 5 years, you have to ask the question, can we give them a break? And that's exactly what we call a drug holiday. Now, the decision to start a drug holiday isn't black and white. It's a real clinical judgment call, and it's based on all these factors. How is the patient doing? What's their fracture risk now? Has their bone density gotten better on the DEXA scans? It's all about balancing the ongoing benefits against the very rare but real risks of long-term therapy.
And what if your patient can't take a bisphosphonate? Maybe they have really bad kidney disease, for example. Well, our go-to second-line agent is a drug called denosumab. It's a monoclonal antibody, works in a different way, but it's also a very potent drug for slowing down bone loss.
And that brings us to our final and maybe most important point. The medications are great. They strengthen the bone, but they do absolutely nothing to prevent the fall itself. And a strong bone that never hits the ground isn't going to break, right? So the real challenge, and honestly where you can make the biggest difference, is thinking about the whole patient, their strength, their balance, their home safety. The question isn't just how you treat the bone, it's how will you prevent that next fall?